Hi, everybody, and welcome to this edition of the Taking Control of Your Diabetes podcast. I am one of your hosts, Dr. Jeremy Pettus. I am joined, as always, by my good friend and colleague,
Dr. Steve Edelman.
And if you're just tuning in, Steve and I have both been living with type 1 diabetes ourselves since we were 15. We're both endocrinologists now at the University of California, San Diego, and both work for the not-for-profit organization Taking Control of Your Diabetes that Steve founded about 30 years ago now. So we're going to get right into this podcast because it's a very special one that we're broadly calling, research breakthroughs in type 1 diabetes. And to help us through this, we are joined by a very good friend and, a true expert in this topic. So, Steve, tell us, who do we have today?
Well, we have a very special guest that is probably the most qualified to discuss breakthroughs in T1D, and that's Aaron Kowalski, who is the CEO of JDRF, now called Breakthrough T1D. And he'll tell us why they made that switch a little later. But, Jeremy, you and I met Aaron way back in 2005 when he left grad school at Rutgers doing biology to join the JDRF and has been there ever since and has been a tremendous leader. And I'll let Aaron tell you a little bit about his background, but he is a member of the tribe. He's got type 1 like you and I, and he also has a brother with type 1. So it is in his genes and his blood and his life and his profession.
I just want to add that Aaron is, I'm touching Aaron right now. He is physically here. It's on his knee.
Well, I can see where you're touching.
He flew all the way from New York to be here. We've had people Zoom in, things like that, but it's so great to have you actually here, give you a tour of the T1D's studio. So thank you for making the trip. But yes, Aaron, tell us about yourself, your journey with type 1, how you got into the space, all that.
Yeah, it's so great to be here with you guys. Great friends. It's an honor. Your place is, I'm going to say, Steve, I knew you when, but you guys are making such an impact, and it is truly an honor to partner with TCOID and you guys. So yeah, I'm Aaron Kowalski, CEO of Breakthrough T1D, just hitting 20 years at formerly JDRF, Breakthrough T1D now. As you said, Steve, I came out of basic biology, protein biochemistry and molecular biology, and joined the organization as a junior scientist. My brother and I have type 1. Steve was diagnosed. He's 2 years younger than me. I'm the oldest of 6 kids, so 2 of the 6 have type 1. In 1977, back in the olden days, and I know you talk about this, urine testing, 2 shots of animal insulin a day. I was diagnosed when I was 13. In 1984, and here we are, come a long way. Yeah, so I joined JDRF as a junior scientist. It's been an amazing 20 years. We've seen so much progress. We can talk about it. Worked on artificial pancreas project, which was fun. A lot of policy work. And here I am now as CEO, which is of Breakthrough T1D, which is absolutely amazing.
Yeah, and correct me if I'm wrong, but the first person living with type 1 to be the CEO of the organization, is that right?
Yeah, it's what an honor.
Yeah.
That's awesome. So glad you got type 1. Aaron, give our listeners a brief reason why the JDRF changed the name to Breakthrough T1D, because I think that's important. It's the first change in 50 years.
Yeah. Well, it's not the first change in 50 years. When I started, in fact, when I interviewed, it was really hard for me to say JDRF because I grew up when it was JDF. And we went to JDRF. They added the R before I was there, research, Juvenile Diabetes Research Foundation. And the long and short of it is, my goal and our goal is to be representative of everybody with type 1 diabetes. That's what we want to do. We want to cure everybody. We want to help them until we're there. And many people saw us as only representing kids, juvenile diabetes. There is no juvenile diabetes.
Well, Jeremy's juvenile, and he's 45 years old.
If anybody's juvenile, it's Mr. Edelman over here.
So it's type 1 diabetes. 50% of people who get type 1 diabetes are adults. And we have people with type 1, not just in the United States, of course, all over the world. So the organization was really looking to be more inclusive of the broad T1D community, represent all ages and stages of the disease, and help anybody that we can who lives with this disease. It was hard. I can tell you guys, there was a lot of passion around this. But I think it's the right thing to do. The feedback's been incredibly positive, and I'm really proud of it.
Yeah, that's awesome. So, I would say that all of our listeners have different kind of, experiences with the organization. Think of them through the walks or advocacy, but the major thrust of what you all do is research and funding research to be done to, promote new advances in type 1 diabetes. And so the other thing actually that where I spend kind of most of my time is actually at University of California, San Diego, doing research in type 1 diabetes. And I'll just say that I literally wouldn't have a job if it wasn't for Breakthrough T1D or JDRF funding the research that we do, funding people to do this research. Because we talked a little bit before on the podcast that, if I wasn't able to get this research supported from organizations like Breakthrough T1D, universities don't pay you, to just go show up and do research. So without money coming in from outside through, organizations like Breakthrough T1D, who was a major funder of these things, there just wouldn't be research in type 1 diabetes. So.
Yeah, there's a rare investigator in this country that doesn't have some connection to funding from Breakthrough T1D. Mm-hmm. And that's certainly true at our university as well. So, yeah, it's a tremendous way to advance the field, and you guys have done so much. And as we were talking before the podcast, you're helping some of these private companies advance their technology, to help us folks living with type 1. And yeah, they better pay you back when they make their gazillion dollars.
They do.
Well, and then we were talking just before we started that, Breakthrough T1D kind of broadly organizes these buckets of research into these 3 buckets. So, and we're going to go through these in the rest of the podcast, kind of tease out some of the details of each of these categories. But broadly, they are 1, improving lives, which I kind of think of as folks like us already living with type 1 diabetes. What are things that we can do to make our blood sugars better, our lives better, reduce complications, all those things. So we'll talk about that. The second big category is in what you're calling disease-modifying therapies. What can we do to actually stop the disease from an immunological standpoint, either before people get it or once they get it? And then the final one is a big buzz going on in this field called cellular replacement or cell therapies. How can we give people beta cells back, transplants, stem cells? That means a billion different things to people. What are stem cells? So let's start with improving lives. And Aaron, maybe first give us a breakdown of what this category means to you, and then how you kind of might tease out what's within that category.
Sure, and the one thing, just going back to your research, and it's been fun to see you do so much in the field, and to be able to provide funding to UCSD and the labs here. To me, the mission being accelerating life-changing breakthroughs is actually more than just research, and we can get into this, but it's every breakthrough starts with research, but ultimately our mission is accelerating life-changing breakthroughs. So you can see where the name.
There it is.
To cure, prevent, and treat type 1 diabetes and its complications. And I always think of us as being successful only when people do better. And that takes research moving through to companies. Steve, as you said, we work with companies, regulatory processes, payment so it's affordable, doctors like you guys prescribing these things, then we're successful. Mm-hmm. And when you think of improving lives, the way I always distill our mission down is the North Star is curing, but we need people to be healthy when cures arrive. Mm-hmm. And to me, that's what the improving lives part of Breakthrough T1D's strategy is all about. How do we make sure that people have better metabolic control? And how do you do that and make it easier? Because if you go back in the olden days, you could have better metabolic control by poking your finger 20 times a day versus 4 to 6 times a day, but it made life harder. And my goal and our goal is, how do you make blood sugars and your diabetes better and with less burden? And that's the crux of that portfolio and what we try to fund.
Yeah, you said one thing that really rings strongly with me is that there's no cure for type 1 at the current time, but we want to keep people healthy so that when that cure comes, they are a good recipient for that cure. And that's what we've been doing at TCOID along with Breakthrough T1D over the past, umpteen years. So we're still waiting. How long, Jeremy? 10 to 15?
10 to 15, just on the horizon. So, Aaron, yeah, within this category, technology comes to mind: continuous glucose monitoring, hybrid closed loop, all that. So, Breakthrough T1D, JDRF, has been instrumental in getting these things off the ground. I think of some of the original Dexcom studies, for example, a long time ago, really funded through JDRF. But now that this has really taken off and these companies are big and huge and things are going, what is your role in helping the further development of these systems, these algorithms, et cetera?
Yeah, we still have some work here, and I grew up in the organization. I used to be thought of as and I'm doing air quotes, artificial pancreas guy, and I'm really proud of that because virtually every technology that's on the market, there's components that we funded built in there, which is amazing. You hear people doing better, but you're right. The companies are doing it. They're off and they're running. So what we always try to do is think of where are the gaps? What could be better? What could we do to move the field forward? We all know that you still have to bolus when you eat. That's a big focus of ours is could you minimize or eliminate the need for a bolus? It's hard. It's really hard when you're delivering insulin subcutaneously. But we're trying to do that smaller. I'm a big believer in interoperable. I was a former looper. We funded Tidepool to bring loop through the FDA. I believe firmly that the future is plug and play in devices, and that things should run off your cell phone. And then adjunctive therapies is another part of this, which is, are there drugs beyond insulin that will help us better glucose control and or reduce complications risk that could be added on to what we do today, again, with less burden, hopefully, to keep us healthier. So, part of it is kind of niche stuff in the devices. I guess one other thing that I would say is, and probably one of my most proud things of my career is the work we've done in pregnancy, for example. We call it special populations, like pregnant women, very young kids, very old people with type 1 diabetes. How do we help special populations do better? And when I hear pregnant women say, I had a baby because of this technology, really.
No, that's awesome. And I'm just, we didn't really plan this out, but we're talking before we did the podcast what system each of us use. And we actually use 3 different systems between the 3 of us, which, something you just wouldn't say even just a couple years ago. And they'll have pluses and minuses and reasons that we use them. So it's so cool that this field has really come along. And, I always talk about, Steve, when we first started talking about CGMs and, people would kind of boo us and you don't need this and you're wasting money.
Patients see their own
too much
numbers.
information.
Oh my God,
too much information. And now it's just duh, it's the standard of care. It's malpractice not to use CGM. So thankfully this stuff is really moving along. But what you said, Aaron, it made me think is that you're saying, so can we use some of these other medications like Ozempic that you see here on TV or Mounjaro or things like that? Could we use medications like that in combination with these hybrid closed loops so people might not have to bolus? And it reminded me that just 2 days ago, I got an email from Breakthrough T1D saying they're looking for applications to fund, research exactly in that area. Hey, if you're an investigator and you have an idea for testing one of these medications, let's hear about it. And that's kind of one way that this works, that there'll be an area of need that Breakthrough T1D has identified. And then through, its channels of the researchers, hey, let's all put our heads together to try to solve this problem. And so as soon as I got that email, I started thinking that's a great idea. I have 10 proposals I could think of to try to move this forward. And so I think that's a good kind of specific example of how this, the Breakthrough T1D connects with the research world to ultimately kind of drive these things forward.
Yeah, it's interesting that you see some of these companies that have these hybrid closed loop systems present data on people who do not bolus. And, you can actually not have to bolus if you just reduce your carbs tremendously, but it's very hard to do. But the data is not bad. You get time in range in mid-60s, including data from Medtronic, the 780G, and some other systems. But I just want to say one thing, how Breakthrough T1D has really helped drive the hybrid closed loop field, that Jeremy and I see patients now in our clinics at UCSD and the VA. It's such a different world than such a short time ago when people had pumps, they had CGMs, but they weren't communicating. And I do believe that all the systems on the market are good, and a certain percent has to come from the user, a certain percent of success. But nowadays, my clinic is so boring. I had Bill Polonsky come to one of my clinics to, just to hang out and help anybody having problems. Everybody was on a hybrid closed loop system. A1Cs were excellent. Hypos were extremely low, which is a huge benefit. And he said it was the most boring clinic he's ever sat in on. And we ended up talking about people's favorite Peloton instructor because there was nothing else to talk about.
Isn't it amazing?
I mean, it's
I
shocking.
Think it makes me so happy. And I meet families who say, I can't believe you used to have to finger poke. And that just is so great. I love that.
Hey, what about us that peed on a stick?
Yeah.
Well,
and you missed.
The goal is to get kind of every clinic to be like yours, like still the majority of people are struggling, not meeting these goals, but this technology is very, very helpful, and it's getting people access to it, getting them on it. Still a lot of like training on how to use these devices, but it's rapidly improving. And I do before we leave this area, just highlighting again, I'm a huge believer that I think very soon getting some of these other medications, like I mentioned, Ozempic, and some of these other pills like SGLT2s, like Farxiga, things like that, actually approved for people with type 1. So it'll be, I hope, let's say 5 years from now, multiple hybrid loop or fully closed loop insulin delivery systems to choose from. And when you see your endocrinologist, your provider, hey, in addition to insulin, which we will always need, you might be able to benefit from one of these other medications to help make your blood sugars a little bit better, help you lose some weight. So I think that field is quickly evolving to think of it a little bit like we do with type 2 diabetes, that we're always using combinations of medications in type 2. And it's just long overdue in type 1 that we start thinking about these other pathways.
Yeah, it's a huge priority for us, and I'll just kind of put a pin in this, in that, of course, we want better blood sugar levels, and these drugs help. But the other thing that we all are at risk for is diabetes complications. And people think, oh, you have a closed loop system, you won't get complications. We still have average blood sugars that are abnormal. And these drugs have an amazing effect in reducing the risk of cardiovascular disease, renal disease progression, kidney disease progression. So for us, the fact that they're not approved for type 1 people is a big problem. Mm-hmm. And we are so committed to getting these companies to get labels for type 1 diabetes so that your doctors will prescribe them and you can be reimbursed for them versus having to fight and having to pay out of pocket, which is just not fair.
Yeah. I have this go-to letter that I've written to insurance companies with all of my references and things like that of why this patient should use Ozempic or whatever it might be, but it shouldn't have to come to that. But all right, so we're leaving improving lives behind. All of our lives have been improved, right?
Totally.
We're all better. So the next one is broadly, it's called disease modifying therapy. So Aaron, what does that mean, and what are some examples of things in this area?
Well, what it means is we've put a Band-Aid over type 1 diabetes for 100 plus years. Insulin was discovered in the early 20s, and we've treated the symptoms of diabetes, not the root cause. So our goal, of course, to try to fix this is you have to fix the disease, and that is an autoimmune disease. So that's what disease modifying means, changing the course of the disease. It's hard. Your immune system is super complicated. It's always changing, it's always evolving, and we're trying to fix something that we don't completely understand even why it happens. All of that said is we're making real progress. In many other autoimmune diseases, there are approved disease-modifying therapies, like for juvenile rheumatoid arthritis or multiple sclerosis, that can go down all the way to kids. We have the first one ever in type 1 diabetes. It was a long, hard process that JDRF and now Breakthrough T1D was very involved in from the get-go in the late 80s. It took from the late 80s to the 2020s to get this drug teplizumab, now called Tzield, approved. But it's the first ever drug in 100 plus years for type 1 people that changes the course of the disease. And what it does is slows the autoimmune attack so that if you're in the early stages of the disease, it takes longer until you get insulin. You need insulin. Our goal is to prevent the need for insulin if somebody's at risk. That's going to take time. We're working on it, but that's what disease-modifying therapies are about. And part of this is in people who are at risk. Ultimately, these drugs will be needed for curing people, I think, as well. We'll get to that, but it's too long. 100 years is too long.
I would say, make the joke that, you can't turn on the TV without thinking that you have mild to moderate inflammatory bowel disease or plaque psoriasis or whatever it might be. So we've had so many drugs and these other autoimmune diseases for so long that like literally it's everywhere. Yeah. And there's lots of reasons why it's taken longer in type 1 diabetes. The beta cells are hard to, visualize. When they die, they don't come back. All these things that kind of stacks the deck against us a little bit. But yeah, now we have an approved drug to delay the onset of type 1. And the other category I would say in that category is what can we do when people get type 1 diabetes? They come down with DKA, they're in the hospital, they still have some cells that are healthy, that are making insulin. How can we preserve those cells? Anything you're excited about in that area?
The same drugs are showing results at the time of diagnosis. The now Sanofi, it used to be a company called Prevention Bio, did a study called PROTECT that looked at that population of people, prolonged insulin production. The thing that's interesting is if you have a little insulin production in your body, it goes a long, long way. Mm-hmm. Dramatically reduces the risk of severe lows, makes your swings much less. So if we can get in and even preserve a few of these cells, it's a big deal. And the results were pretty striking. So we have a number of companies that we're working with and research investigators who are trying to lengthen the time that people stay insulin independent and ultimately prevent the disease completely.
And it's such an important area for a lot of reasons, but I would say it was probably the number one kind of group of people that reach out to me is, hey, I was just diagnosed with type 1 diabetes, or my son or daughter was just diagnosed. Mm-hmm. There's got to be something we can do to, help target the disease. Yes, we're going to, get the CGM and the blood sugars and do our best to get this under control. But you're just telling me that we got to, wait for these beta cells to die. So there's so much active research in that area. And if people are newly diagnosed or know somebody that is newly diagnosed, that's an area to look into. You have a finite amount of time that you can do a research study. So that's a good time.
It seems like there's more and more companies interested in that space too. Mm-hmm. I think TZL just opened the door at the tip of the iceberg. And for the listeners that aren't familiar with how that drug got approved, it was a study in what we call stage 2 where there are no symptoms. It took them 7 years to recruit 73 patients because if you don't have any symptoms, and as you said, well, you didn't say this earlier, but most people that are diagnosed with type 1 do not have a family history. So I think screening is a whole nother area. And so that field has exploded.
Yeah.
And teplizumab is the first one.
Yeah.
And it's amazing.
I always say, like you said, Aaron, like people are finally remembering that type 1 is an autoimmune disease. Like what is, as endocrinologists, we're not trained on T cells and, immune attack and these things. We're very good at addressing blood sugars and insulin and metabolism. But this is, again, reminding us, oh, yeah, like this is a disease of T cells that are attacking the beta cells. And what can we do to kind of, address that? So much education going on in the community, educating providers. That's so important. So,
yeah. And I would just say, Jeremy, we Breakthrough T1D, we're really focused on screening. As Steve pointed out, many people don't know they're at risk. And many of the listeners understand diabetic ketoacidosis and know how dangerous it is. It's preventable in new onset if you know you're at risk. We had a girl in New Jersey who died during COVID. The parents were scared to bring her to the doctor. She had flu-like symptoms. She had type 1 diabetes, undiagnosed. Diabetic ketoacidosis, fatal, totally preventable. So screening, not only can we get these now disease-modifying drugs into people, we can also prevent one of the most dangerous complications of diabetes by knowing you're at risk. So this is another big priority of ours.
Mm-hmm. And we've done a number of podcasts specifically on, kind of teplizumab screening, things like that. So if you're interested in more information on, I have type 1 diabetes, but I want to get my kids screened or my family members, all that, please check out, one of those podcasts where we go into a lot more detail. But, so the final category, cell therapy. So the way I think about this, I want to hear what you think about it, is, okay, I've had type 1 for a zillion years. I'm on my CGM and my pump, and I'm doing all right, but man, I'm tired of this disease. And this is probably the second most common question I get is, can I get some of those stem cells? Like, just infuse them into me, give me some beta cells back. I'm tired of this disease. And people just kind of ask me, where is that at? And so tell us what cell therapies means to you and Breakthrough T1D and where it's at.
Yeah, I always say that when I would go to the one conference with you guys and come up and talk about curing type 1 diabetes, I would look out in the audience and the skepticism level, it was always the 5 to 10 years, right? And I'll just to very quickly give you why that happened. Islet transplantation, so this is where somebody dies, donates their organs, you take the pancreas, you take the cells out that make insulin, the islets, plus glucagon and other hormones, and you transplant them into people. And what transplant means is it's actually an infusion of those cells into a vein, and they settle in your liver. And it actually cures people in their minds. Now, we can debate, is that a full cure? Because it requires a chronic immunosuppressant. But I've met a number of these people. They will flat out tell you they're cured. They're trading their type 1 for immunosuppression. Mm-hmm. But imagine being at a meeting and seeing a fellow type 1 friend who back in the 90s and 2000s was getting low all the time, and then they're off insulin. So I think everybody thought, oh, it's right around the corner. The problem was it wasn't scalable. Mm-hmm. You needed people to die. And then you have the immunosuppression issues. But where we are today is we've invested formerly JDRF, NIH, many philanthropies in stem cell research. Can you make these cells into insulin-producing cells? And how the data is showing is that you can. It's amazing. I'm sure we'll talk about the Vertex data. And for me, I very much believe this is the pathway for me to take my pump off and you guys to take your pumps off. I believe there'll be a product in this decade, a stem cell-derived islet with immunosuppression on the market in this decade. And that won't cure everybody because, again, you'll need to take immunosuppression. But it will cure a decent amount of people. Now, unfortunately, we estimate about 10,000 people already on chronic immunosuppression because they had kidney transplants due to type 1 diabetes. Imagine if all those people could come off to their insulin tomorrow. That's huge.
Yeah.
So our push at Breakthrough T1D is immunosuppression-free stem cell-derived islets, and that's where we're going to be investing heavily.
What about the promise of the little capsules that people put islet cells in? I know Vertex has a protocol they're working on right now.
Yeah, so the way we see, if you look in the crystal ball, we think Vertex, that the trial most of your listeners probably heard about it, VX880, is doing, we call them naked cells, so they're infused without any protection, and you need the immunosuppressant so your body doesn't reject them. We would call that kind of product 1, V1. V2 will probably either be an encapsulation device like ViaCyte. Jeremy, you worked on the ViaCyte device. Vertex has a new device. Or a combination of the naked cells with a more mild immunosuppressant. The Holy Grail is a gene-edited line, meaning the cells we call it the Harry Potter cloak of invisibility. You get those cells in and the immune system doesn't recognize them. We have a future to really not wearing devices anymore and having normal blood sugar. But the VX880 trial, the data we saw in Orlando, is unbelievable. People start with 40% time in range, and at 6 months, they're 97% time in range. Start with 45 units of insulin a day. At 12 months, there's 0 units. At 6 months, it varies. It's like 5 to 10 units. I mean, so part 1 of the puzzle seems to be pretty close to being solved, meaning a renewable cell source. And the big push in my mind for the research community is take away the immunosuppression.
Mm-hmm. No, that's exactly it. And so when people ask
makes
me,
common sense.
Should I go enroll in one of these studies? And it's not there for the masses yet. We have the cell source that we can make enough cells for everybody, but still requiring immunosuppression, which has side effects. These protocols right now are limited to people that have severe kind of unretractable hypoglycemia that they're dealing with. So that's who's currently enrolled. However, if you take away the need for immunosuppression, that really changes the risk-benefit ratio to, well, now there's not really that many like risks associated, and then it could become really for essentially everybody. And I like how you laid that out. Yes, we could try encapsulating them. We could try to make these cells invisible to the immune system. And that's going to be the next step that would really kind of open up the door. That'll probably take 10 to 15 years.
I like the naked part, to be honest with you.
I knew I was waiting for you to protection, naked. I was like, where's Steve going to jump in with this?
I do have a serious comment, though. Us physicians and anybody in the medical field, they hear the word immunosuppression and it's like, oh my freaking God, no way. But I think we have to redefine what that means and really talk about the true risk-benefit ratio. And I think we have given it a bad rap, and we do have better cocktails these days for people with kidney transplants and other organ transplantation.
Yeah, and this is not a solid organ. So I'm fully with you, Steve. As Jeremy pointed out, the trial is currently pretty restrictive. My feeling and our feeling, and we're lobbying the FDA on this front, is if I'm a cogent adult working with my physician, I should be able to make that decision. Mm-hmm. And it should be much more broadly open because the risk benefit is on the table. Type 1 has significant risk. So if we can make those decisions, now again, the goal is to minimize or reduce or eliminate the need for immunosuppressions. But in the meantime, some people will benefit from this.
Yeah, and I agree that giving people the choice, because some of these protocols will say you have to have two severe hypo events in the last 3 months, and I've said, well, I could have 2 severe hypos today if you want me to. So that's ridiculous. You shouldn't.
I dare you.
So it's a long. All this is a way of saying, when people say, what's going on in type 1 research, there's just so much, like so many different angles. And, even when are we going to have a cure? That's nebulous. What are you really talking about? What if you were on a pump that you didn't have to deal with? Is that a cure to you? Cure means different things to different people too. So all these buckets are meaningful in their different ways, and they're all moving forward very, very quickly. I think, kind of thinking back to some of the meetings I've been at Breakthrough T1D of everybody kind of speaking up for their areas, and we got to invest more in these disease modifying approaches or cell therapies, and they're all very valid. So I think that's good news for our listeners is don't worry. This is moving forward. There's a lot of smart and dedicated people working on this. And in the meantime, we've got these rapid developments of artificial pancreas and things like that are happening on kind of a daily basis. So any closing thoughts, Aaron, or things you want to say to our listeners?
Our purpose statement is as we drive towards curing type 1 diabetes, we're going to try to make everyday life easier for the people who face it. And I think that we've seen a lot of progress. My life is certainly easier and healthier since I started at the organization. My brother, who had many, many severe hypoglycemia issues, is healthier and easier. And I do believe I'm going to take off my pump. So, Breakthrough T1D, I'm so proud to be partners with TCOID. You guys are my idols. You guys do so much for our community, and to me, it takes a village. So, for the listeners, get involved with TCOID, get involved with Breakthrough T1D, and let's make that take the pump off happen sooner.
Boy, feelings are mutual, my friend, and I heard you say this decade. So that's in the next 6 years. So, and what's going on better than any one of us at this table.
Well, I was just going to say, I took off my pump in the shower, but this morning, we're talking a little bit longer term. But
my Omnipod, I could wear it in the shower.
Well, thanks so much, Aaron. It's been great. We love having you on. We'll do this, as much as we can, because I'm sure our listeners enjoyed it too. And thanks everybody for tuning in, listening in. And if you like this, make sure to like, share, follow, all those kind of fun social media things. And we will talk to you on the next one. Take care.
Thanks, Aaron.
Thank you, guys.